Maybe what I could do at this point is let people know about a couple of the other things that we've got planned in the future, some of our outreach program. We have a series of workshops called the eHealth Risk Workshops. And we've got a brand new one called eHealth Information Security Workshop. That's aimed at trying to provide the information that professionals need to provide a secure system in eHealth systems. That's going to be held Wednesday, March 26th. Starts in the evening and continues to Friday, March 28th. And it's being held right next door in DC 1302. So there's information on our website about registering for that workshop. The website is hi.uwaterloo.ca. And from there you'll see a link to the workshops that we're holding. The other two workshops are the Health Information Professional Workshop and the eHealth Risk Opportunity Report Card Workshop. Those are going to be held back-to-back in April, so starting Tuesday, April 15th to Wednesday, April 16th, and then followed by the Health Privacy Professional Workshop the 16th and the 17th. So if you're interested, please visit our website on those workshops. So for people that have just arrived, we haven't quite started yet. I was just making some preliminary announcements for those of you that are interested in some of our other events.
Jessica's not allowed that night.
We have some drinks and cookies at the front, so if you'd like to help yourself, please do so. So do you think we're ready to go? All right. Well, it is my pleasure to welcome you all here today for our first research seminar for 2008. A belated Happy New Year to everyone. And I'm particularly pleased that we have Ann Pidduck here to talk to us about electronic social networks and dementia prevention. We had Ann try to give us a seminar last year, and lo and behold, we had a fire alarm in the middle of the seminar. So we got just to the exciting part of the presentation, and we all had to leave.
I'm pulling it early this time.
So we couldn't let that happen. We had to invite Ann back to give her presentation. I think it's actually evolved over the year a little bit. So, but we're very pleased that Ann has agreed to give this seminar for us today. Ann is a faculty member in the David R. Cheriton School of Computer Science at this university. Her research and teaching interests include health informatics, information systems management, and software engineering. She works a lot with health information-related technology projects with, for example, KPMG Management Consulting, Ontario Nurses Association, and the Construction Safety Association. Ann has her PhD and Master's of Applied Science degrees in Management Sciences and a Bachelor of Applied Science degree from the University of Waterloo. She's also a registered professional engineer in Ontario. So please welcome Ann Pidduck.
Thank you. So I gave a talk last year that just had dementia prevention in it. It didn't have electronic social networks. So I noticed electronic social networks has brought a few more people out. Very, very exciting topic, or much more exciting than just dementia prevention by itself, I guess. Also, I'd like to mention that the research is research in progress, which is to say that we're just starting this research and we're happy to get whatever input you would like to provide. So anybody who has information that they want to provide to me after the session or during the session, feel free to put your hand up. Feel free to let us know what you're talking about. So this is a quick overview of what I'm going to be talking about today. The first three pieces, the motivation, the dementia prevention, and the social networks, are background on why we're interested in this type of thing, where we're going with it. Then towards the bottom here, electronic social networks, we'll talk a little bit about differences between electronic social networks and physical social networks. than our research. So we've just done a little bit. We've just been working through maybe the last 6 months on this topic, and a prevention model that we've come up with, and then some conclusions. So motivation. These are some of the statistics, and I do have a lot of facts and figures in this presentation. If you're interested in any of my sources, I can provide them for you later. 24 million people with dementia worldwide, 81 million, this is the anticipation by 2040. Alzheimer's disease accounts for 64% of all dementia in Canada. So as I've been doing this work, I've been working on it probably in total for a year, year and a half, I guess. There's constant confusion or constant discussion as to what's dementia, what's Alzheimer's disease, what's Alzheimer's disease dementia. The dementia that people are concerned about, the dementia that people are talking about constantly is this Alzheimer's disease dementia. So that's the kind of dementia that I'm talking about. 420,000 Canadians have AD or a related dementia, and I'll show you a statistic later that is different than this one, but is also very interesting. And AD is the second most feared disease among Canadians. So that was just our numbers motivation. Now our cost motivation. 18.7 million spent on research by the Canadian government. But contrast that with the second point here. The cost to care for Alzheimer's patients is already 5.5 billion. So if you put these two numbers together, the cost is 300 times the research spending. So lots of people are getting interested in prevention these days. Rather than spending more time on facilities to look after these people, more doctors, more nurses, let's prevent it in the first place, and then we're going to save ourselves a lot of money. And then the last statistic down here is just to compare this to the US. So $100 billion cost in the US. So huge savings if we can prevent some of this disease, even just a small part of it. All right, so what is dementia? Dementia is mental decline beyond the normal effects of aging. This, again, is related to Alzheimer's dementia. Problems with attention, language, problem solving. Later, people are disoriented and confused. AD is 64% of all dementia in Canada. So as I said, this is typically what we're looking for. And as you read stories about people who gather Alzheimer's and progress through Alzheimer's, first thing that goes is the memory. After that, they lose their personality, they lose their independence. You don't know who that person is. So that brings us to a diagnosis. How can we know whether you have dementia or you don't have dementia? So the assessments that are done, medical and neuropsychological assessments, are done by doctors, by trained professionals. Most people still living in their own homes never have such diagnoses. So we're trying to hit people before they have the dementia. These people are still in their homes. They're never going to get, unless they actually get dementia and move into a nursing home, they're never going to get that dementia diagnosis. And so this is for dementia, and then for Alzheimer's disease, the diagnosis is typically not until after death. So again, the diagnoses are too late. We want to hit them before they get the dementia. All right, so that was the dementia information. This is the Alzheimer's disease. Alzheimer's disease is a neurodegenerative disease characterized by progressive cognitive deterioration, so this is the memory going, together with declining activities of daily living and neuropsychiatric symptoms of behavioral changes, the most common type of dementia. So this is the concern for people. Some of the risk factors, these are some of the institutions in the States that have come up with these risk factors. Age is one of the biggest risk factors. Genetics is a second risk factor. And this last point is about the specific genetics. So this APOE is found in about 40% of people with Alzheimer's disease. And we'll talk a little bit later about genetics and how we can possibly make use of genetic testing to help in our prevention. And this is also a little bit more about the Alzheimer's gene. There are a number of genes, there's a number of studies going on about genetics. And if you have these genetics, if you have this genetic predisposition, can we indeed prevent dementia? All right, these are the numbers that I was going to compare to the 420,000 that I talked about earlier. This study was done in 1991. And in 1991, they were looking at the males, the females, and the total population that had Alzheimer's disease and that they expected to have, dementia, that had dementia and that they expected to have dementia. So their projection to 2011 is just over 150,000 there. Their projection is, let's say 175,000. Actual numbers today were 400 and some odd thousand. So the actual numbers today are double what they thought they were going to be back in 1991. So the concern with that is if we're projecting now 10 and 20 years into the future, which we are, maybe our predictions are going to be too low as well. Maybe we're actually going to have a worse problem than we anticipate.
Were they sort of forecasting new cases? And
They,
what you're looking at for the 470,000 is the prevalence, the new cases plus the,
okay, that's very possible. The question is whether they were forecasting new cases or not. They were forecasting, I guess, with information they had, assuming that the population would stay the way it was. So they were anticipating new cases as the population grew. Yes.
By the way, if you can keep the questions till the end, or give me a chance to get you a microphone so that we can record. This is all recorded.
oh, I see.
Okay, no, but I would like questions as we go along. So if we need a microphone, we'll get a microphone. That's fine. All right, so I just found that interesting because, as I said, they hadn't anticipated the problem that we do have right now. All right, so these are other interesting statistics. So this is from the Canadian Study on Health and Aging. Roughly 8% of Canadians aged 65 or over suffer from dementia. Okay, so that's not a big deal. Who cares? But look at these numbers. These numbers are very interesting. Prevalence rises steeply with age. So it's 2% among people aged 65 to 74. So if you're 65 to 74, you might get dementia, you might get Alzheimer's, but probably not. 11% for those 75 to 84, so significantly more, and 35% for people 85 and over. So as you get older, your chances of getting dementia are significantly increased. So this ties into what we're trying to do with prevention. And when I first started looking at prevention over a year ago, there was a lot of this talk about delaying onset of dementia. And I thought, well, that's kind of a stupid idea. Like, why would you delay onset? Why don't you just prevent it entirely? But the idea of delaying onset is average age of onset is 70 to 75 years. If we can prolong it by 5 years, then it would be 75 to 80. If we can prolong it by 10 years, we can virtually eradicate it because people are going to die. I mean, it sounds awful, but people will die before they get the dementia. So this strategy of delaying onset isn't as ridiculous as it seemed when I first started looking at this. All right, so what are some of the prevention things that you can do? These are the top 6 ideas, and this list was culled from a number of different locations. One of the things they suggest is diet, another nutritional supplements. So there are a number of vitamins, a number of natural supplements that people can take. Physical exercise, mental agility, and a whole bunch of game playing and quizzes and that kind of thing they talk about. Social networks and stress management, keeping yourself relaxed. So we looked at this list a year ago and started thinking about these social networks. And we thought, well, the social networks are interesting. And at the same time, we were hearing people talking about these electronic social networks. So there's a little buzz on both sides in terms of whether social networks or whether electronic social networks would make a difference, would help or not. Another interesting thing about this list is you'll see this same list for a lot of diseases. So this same list shows up for diabetes, it shows up for cancer, it shows up for heart disease and stroke. Not necessarily exactly the same list, but these types of things, they're saying get yourself in shape, keep yourself in shape in these areas, and you'll help prevent a lot of different things. All right, so from that list, we came up with a dementia prevention model, and this is what I presented a year ago, or this is what I tried to present a year ago when we had the fire alarm. So we have on the left-hand side a number of areas of research that we're using to gather information. So there's risk research in terms of risk of getting dementia, risk of getting Alzheimer's disease, dementia research, Alzheimer's disease research, and a user profile. And typically the user profile would be to look at things like genetics, whether you have a genetic predisposition to this type of thing. Then in the middle of the model, the things that we looked at, social networks, mental agility, physical exercise, diet, and nutrition. So the idea in the center here was to set up some sort of computer system that looked after this type of thing on an individual basis. And this part in the middle, the idea was to prevent the dementia in the first place. Once you do get dementia, though, if you get dementia, then you end up over in this diagnosis side. And on the diagnosis side, there is medication. There are several kinds of medication that'll slow the dementia or slow the Alzheimer's. And then what I've called caretaking technologies. So this is information for your caretakers. So as people get dementia and as they start to decline, they can't look after themselves anymore. You can't trust them anymore in terms of whether you ask them whether they have dementia or whether you ask them whether they have a problem, whether there's an issue. You're not getting appropriate answers back. So there are caretaking or there are technologies for the caretakers. I guess that's what the FART technologies are for. All right, so this is where we were. This is where we were a year ago. As I said, we started to get a little bit excited about social networks, or we started to decide that that's what we were going to focus on was social networks and looking at it in relation to electronic social networks. So that's the next piece, the next place that I'm going. So in looking at social networks, what was it about social networks that caused people not to have dementia? So monthly activities, so there was this notion of a regular social network. Contact with children and relatives, particularly these were older people that were being studied, so their contact with children and relatives was very important to them. This whole notion of family and friends. A lot of them did have friends, but if they had family, that was a really good connection too. Membership in a social club or group, this was good, again, because it gave you kind of the regularity of monthly activities. And then another interesting thing that comes out in a lot of the literature is that social networks can be tied to other preventive aspects. So if you have a book club, then you have mental exercise. You're keeping your brain active as well as the social activity. If you join a dance group or an exercise club, then you're getting your physical exercise plus you're getting the social network. So the combination is better than just thinking about a social network. So for social networks in health, less cardiovascular disease, less depression, less diabetes, stroke, high blood pressure, and this prolonged time to develop dementia. So this notion of if you do get dementia, it's going to be delayed a little bit. And lots of studies to show this. So I have some of the studies coming up in a few minutes. All right, so what do various organizations say? So these first couple of slides are Alzheimer's organizations. Social interaction, if you have an active social life, if you're active in retirement, if you have positive attitudes, that all helps in prevention. If you exercise your brain, experience new things, make positive friends in every generation. So again, a lot of the studies showed children, middle-aged people, older people. So you're not just dealing with old folks, but you're picking up new ideas as you go along. That's positive for you. Social engagement, intellectual stimulation. This is a U.S. organization at the bottom. Lifelong mental exercise and learning. So this notion of learning, some of the studies have tied social networks to education. Maybe only 1 or 2 studies that I saw tied them to education. But the idea of lifelong learning shows up in other preventive literature. Exercise and brain aerobics, and some of these websites actually have exercises for you to play with. And stay engaged in social activities and exercise your mind. So these are all a variety of different organizations, all saying the same thing or different variations on the same thing. Then a couple of research articles. So those first couple of slides were from the Alzheimer's community. The next couple of slides are from the researchers themselves. What are the researchers saying? Social networks offer a protective reserve capacity, sparing manifestation of Alzheimer's disease. They studied 89 elderly people without known dementia, looked at things like children, relatives, monthly visits, and then came up with this conclusion that I have at the top, that if you have the social networks, if you interact with children, relatives, and have monthly visits, then you're less likely to get dementia. Alzheimer's Society of Canada, socializing with others helps you stay connected mentally. Social interaction appears to provide a protective element. And then they have a number of suggestions for you. Talk, email, communicate. They have a quiz. They have a couple of quizzes. A lot of these Alzheimer's sites do have this type of thing on them. Maintain old friendships and make new ones. So again, this idea of different kinds of people and different kinds of learning. And Alzheimer's Education and Referral Center, this is in the States. There's a link between social engagement and cognitive abilities. They looked at you having lots of friends, or they encourage you to have lots of friends and acquaintances, many social activities. And they had a large project in 2006 where they studied a number of these issues. All right, so now the research, the academic research. Prevention strategies are available for Alzheimer's disease and dementia. So this is a 2007 study, and for a lot of years, people weren't thinking about prevention at all. They were thinking about, as I said, after the fact, how can we help people after the fact? So it's good to start seeing people saying that, yes, it can be prevented. Intellectual and social stimulation protects against dementia. Again, an academic study that has results to show that. This project in Sweden, let me see if I can pronounce it, Kungsholmen project in Sweden, studied people who live alone with no social ties and compared them to married people and those with strong social networks. So they were looking at the isolation factor, a long-term study of Alzheimer's disease risk factors, and they looked at a variety of stages of life. They looked at birth, during childhood, in adult life, and in old age, and they still came up with this study, with this comment at the bottom. Poor or limited social network increased the risk of dementia by 60%. So this is a huge figure. 60% is you're 60% more likely, or 60% more problem if you have a poor or limited social network. All right, and a few more. Even small contributions of the mental, physical, or social components mattered when they were accumulated. So you had a couple of things going on. Engaging in activities that cover more than one of these. So this is the notion of doing 2 or 3 things. The book club or the exercise group seems to be more beneficial than to be engaged in only one type of activity. And these, again, were academic studies. This one is a little controversial. The human brain may be able to repair itself or regenerate. So this is a 2007 study Burke has evidence, says he has evidence, but says it's controversial evidence. So whether no one has been able to repeat his study yet, I'm not sure exactly what the controversy is, other than people don't believe that the human brain may be able to repair itself or regenerate. But I guess his idea is that if you start to get Alzheimer's, if you start to have these problems that they talk about, then maybe we can back you out of it a little bit with his idea. Whether that's true or not, I don't know. As I said, it was a 2007 study. So social engagement is associated with positive effects on cognition in humans. Similar positive effects have been observed in social relations, social support, social ties, and marital status, living arrangements, and social network indices. So more studies that repeat this notion of social networks being excellent. Another interesting thing that came out as I was looking at the social networks was the notion of depression. A few people talked about depression. So lack of social support, particularly from family, is positively associated with chronic lifetime depression. And then the second half of that, depression may lead to or be clearly related to dementia. And there are a number of studies that say this. So this could be a whole different avenue of research. It is actually a whole different avenue of research, is the notion of depression leading to dementia. So I just left that off on the side, but I did find it interesting as I was going through. German study coming up with psychosocial networks, including marital status, confidence. So they looked at, who do you feel comfortable, or do you have anybody? Do you have anybody that you feel comfortable talking to, that you feel comfortable giving information to? Close relatives, sports activities, cultural activities, club membership, and education. So they looked at all these things up top. Then what they found significant was what I've listed at the bottom. The number of confidants, so how many people you feel comfortable expressing problems to. Number of sports activities that you do, number of cultural activities that you do, significantly decreased your risk for dementia. All right, so positives from social networks. Why are social networks positive? Individuals can draw on resources from other network members, so you can gather information from other people or you can talk to other information. Various forms of social capital are related to psychological well-being, such as self-esteem and satisfaction with life. So you feel good about yourself if you have this, if you have these social networks. But you can have bonding social networks with family and friends, which are the kinds of social networks that we're talking about. Or you could have bridging social networks to gather information. So some of the people that we looked at who were using electronic social networks were using it just to gather information. And just gathering information is not as good as this notion of back and forth activity with family and friends or with people that you want. So the characteristics of the positive social network: regular contact, interaction. There has to be some form of two-way communication. It's not enough for somebody just to contact you. You have to get back to them, or you have to communicate with them. Some kind of brain activities are good, a book club or a bridge club or something along those lines. Physical activities are good, yoga class, exercise class, anything along those lines. And the last point here was to get out of the house. So this is where the question comes up with electronic social networks. People are thinking, you know, you're sitting on a computer, you're just playing on a computer, you're not talking to anybody. Surely that's not giving you the same benefits as a physical social network. So we have to think about that. All right, so this is just to remind you where we are. We've looked at these top 3 areas: motivation, dementia prevention, social networks. We'll talk a little bit about electronic social networks, and then we'll talk about our research and the extension of that prevention model. So we're just trying to see whether electronic social networks are as good or could be considered to be as good as physical. social networks, or what I'm calling physical social networks. So the research questions: what are the benefits of a social network? So that was pretty much what we just did. And then the second question: does an electronic social network provide the same benefits as a social network? So are we getting the same benefits? And if we are getting the same benefits, then presumably we can say that that's also a dementia preventive. So some of the work that we looked at on electronic social networks. First one is exactly what everybody thinks. Internet use detracts from face-to-face time with others, so it reduces your social capital. So this first point is you shouldn't be using the internet, or if you do use the internet, you're losing that contact with people. The second one is, second suggestion here, conflicts with the first. Online interactions may supplement or replace in-person interactions, mitigating loss from time spent online. So this second one is saying, yeah, you're going to lose a little bit, but you're going to gain more. And a lot of the work that I saw was more along the lines of this, this second idea, that yes, you'll lose something, but you'll gain something else, rather than a complete negative. So we have a study of Facebook Friends, one of the most popular electronic social networks. Study of college students found improved psychological well-being, suggesting that it might provide greater benefits for users experiencing low self-esteem and low life satisfaction. So one of the positives about these electronic social networks is you can be afraid. You can sit in a corner and play on a computer, and it's not as frightening as going out and physically talking to people. So maybe this works well for some sets of people. Another study on electronic communities. Geographically linked communities, such as the Netville community in Toronto, have concluded that computer-mediated interaction, so these are communities in Toronto that are all hooked up to each other, have had a positive effect on community interaction, involvement, and social capital. So these people talk to each other electronically, neighbors talk to each other electronically, and after that, or because of that, or supplementary to that, they have physical social interactions. So that's very positive. Online social networks may lead to offline social networks, so we saw that in an earlier study. There is a positive relationship between use of Facebook and social capital, so that's positive. Now, this particular study was college students, so this is not older people. This isn't the study group that we're looking at in terms of dementia prevention, but these are the people who are using Facebook. Social capital are the resources accumulated through the relationships among people. So this is how we know whether we have good social capital or we don't. So some benefits for online social networks. We can gather or share information. And as I said, if it's a one-way giving out information or bringing in information, then it's not as positive as if you're passing information back and forth, back and forth. Emotional support, particularly for health, companionship, and friends. And one of the interesting things out of both of these studies that I've listed here, depth and breadth of relationships. The more you put in, the more you get out. So just like in physical social networks, when you get talking to people and you get engaged, if you do the same type of thing electronically, then you get more out of the experience. So there is more of this back and forth, back and forth, back and forth. Additional benefits related to the electronic social networks. The physically disabled don't need to leave home. The geographically isolated can participate. So somebody way up in the north can participate in whatever discussion is going on. There are these online support groups and discussion that are less threatening than going in person. And because of that, you can have anonymity if desired. So some of the health application areas: invalids, people who can't get out, physically or mentally disabled people. So there are a number of electronic resources for both physically and mentally disabled people. And if we could take them and use them, they could help in health areas. Older people who can't get out much can get on the computer, and people who are inside because of climate, and whether it's because they are up north or because it's normal Canadian winter, either way we can take advantage of the electronic networks. So what are we going to call an electronic social network? So we've listed a bunch of things here. Number one thing is telephone, and this, I'll go through the list and then I'll maybe talk about why I have telephone in the list. So we have telephone, we have text messaging, we have Facebook, MySpace, LinkedIn, and so on, electronic mail, instant messaging and chats, and internet phone calls, including webcams. So this is something like a Skype. I'm not sure how many people have used Skype, but it's a phone over the computer. So the reason we put telephone in our list, and this was the list that we made for our research study. So we went out and did some interviews. We gathered some data in a survey. And this is what we suggested to people they might include as part of their electronic social networks. One of the reasons we included telephones is because we were talking to people about older people. We were talking to people about their mother, their father, somebody who might be inside, and that's the only connection that they have is the telephone. So we wanted them to feel that there was something they were doing that wasn't a face-to-face social connection that we could count as an electronic social network. Over and above that, the text messaging and the Facebook, number of younger people use that, and by younger I mean 50 and 60 were even using them, but the people who are 70 and 80 weren't necessarily using these technologies. Electronic mail, everybody was using. Even older, 70s, 80s, everybody was using email. So it was a very popular electronic network. Instant messaging and chats, again, a few people using that, not too many. And the internet phone calls, people who had connections far away were using the internet phone calls. So if your granddaughter, for example, was on a trip in Europe, then people were using these internet phone calls. So we gave people a variety of things that they could call an electronic social network. The other thing that we mentioned in our study is we said to people, we have to have this notion of interactivity. Not enough just to have someone else contact you, so you can't just be sitting at home and have your granddaughter phone you. That doesn't count. You have to be engaged. So there has to be a response, and there has to be an ongoing back and forth dialogue in order to call this a social network. So if social networks are good, shouldn't electronic social networks be just as good? And our counter-intuition was, if one considers that people who spend too much time on computers are considered to be antisocial and often prefer to be alone, they're often called isolated, they're often considered to be social outcasts, so maybe electronic social networks aren't as good as social networks, and we have to explore that. So our study looked at 43 people. And we started this with workers. This is why the first couple of groups up here are workers. Invalid workers and virtual workers. And what we were looking at were their communications with the office, whether they had good communications with the office, or whether it was just a different way of passing information back and forth, but there was no actual communication going on. And then we interviewed 30 adult children, and we interviewed these people about their parents. So it's about their mothers or about their fathers. The reason we did this is because, as I said, with the older people, you often can't trust what they're saying. If you're not sure whether they have dementia, whether they're on their way to dementia or not, you can't trust them. So a lot of the work is done with adult children of older people. So we counted the frequency and duration of electronic communication with their close friends and family. We had interviews, and we had a short electronic communication survey. The health data was self-reported. So again, in terms of the dementia, neither the researchers nor the participants are qualified to diagnose dementia. So the researchers, we had 3 of us working on this, and we're all in software engineering or information systems. So we're all kind of computer people rather than medical people. So we're not qualified to diagnose dementia. So the focus of the study became the similarity between social networks and electronic social networks. So if things were true for social networks, so this last point down here, if social networks help to prevent dementia, then that result could possibly be extended to electronic social networks if we can say that electronic social networks provide the same benefits as social networks. So our methodology, we did a review of the literature, so that's a lot of what I've provided already. We did our interviews and our short survey, open questions, exploratory, descriptive. We let people tell us what they wanted to tell us, and then the health and wellness data was self-reported. So these are the results from our 43 interviews. Down the left-hand side, we have the electronic social networks. So we have the telephone, the text, Facebook. When I say Facebook, I mean these electronic social network sites, email, instant messaging, chat, and I put this down as Skype. This is the internet telephones. So out of 43 interviews, everybody used the phone, everybody used email. So that was actually surprising to me. I guess I expected everybody to use the telephone. I didn't expect everybody to use email. Next most numerous was Facebook, and this was from the younger population. These were the younger interviewees. These were the workers that we talked about, or people, probably people up to age 70, but not including 70 and beyond. Usage, again, telephone and email were used daily, so very, very popular in terms of connection. And the duration, we were trying to sort out how long you had this connection, how long did you have this electronic networking. For the telephone, there were both short and long connections. For email, there were both short and long connections, which is to say some people had a quick and dirty email, others wrote a big long email with a lot of information in it. And then the other categories were as we've listed them there. So the results, or more results. An average of 15 emails sent or received daily, an average of 3 telephone calls daily, reported positive electronic communication experiences. So we asked about these notions of isolation and concern. No sense of isolation with respect to the electronic social networks, and health remained unchanged or improved. But as I said, these health results have to be taken with a grain of salt because they were self-reported. And a lot of the studies that we looked at on dementia prevention, the health was self-reported as well. So it's all right, but it's not great results. All right, some of the comments we got. He dresses much better now. He goes out more since he's been emailing the family. She can't wait to hear from the grandchildren. She loves following their journey through their pictures. So this was an older person who was using one of these Facebook sites or a Facebook-like site. She was watching as her granddaughter was touring Europe. So that was interesting. Dad is even bowling again. I thought this was interesting because we're asking about people sitting at home playing on the computer, and the response is that they're feeling so good that they're getting out of the house. So we've got this getting out of the house notion. And the last comment here was from one of the workers who was doing a virtual connection. I'm definitely an active part of these virtual meetings. So I think as we progress with this work, I think we're going to have to start pulling out the workers because their comments are a little bit different than the dementia. They're looking for different things from their electronic connections. So their motivation to use the electronic social network. Why did they use it? Keep up to date, to connect at a distance, to see pictures or people, to get information from work or friends, to share information or help each other. So this is starting to get very, very close to what we saw in the physical social networks, to belong or to meet others. So the bottom ones here, again, are a little bit more related to the people who were working rather than to the older crowd. The limitations of the work. We need to remove electronic organizational networks for a focus on social networks. So this is pulling out those business people. Second problem that we had is we need to control for physical social networks. So if we're saying that the electronic social networks are positive, maybe it's because these people already have good physical social networks. So we really need to find people who have no physical social networks, people who are isolated, people who are invalids, for example, who don't have any physical social network. And if they don't, then we can focus just on the electronic social network. So if they also had a physical social network, it's hard to separate that out. The self-reported health was an issue, and the positive experiences in the health could be tied to so many other factors. There are so many reasons that we could be getting the results that we got. So we need a representative sampling, we need a larger study group, and we need interviews with spouses and elders. And by elders, I mean the older people themselves rather than the adult children. So again, we followed what other people had done in terms of interviewing children, but it would also be interesting to interview the older people. All right, so strengths of our results. We have popular technologies, proven social network results, easily understood and interpreted, and represent complexity in a compact form. The negatives, the organizational electronic networks, so these are the business networks, are kind of confounding things. The physical social networks are confounding things. Self-reporting health and experience, and again, there could be many other factors to explain results. Very difficult to pull out just one or two issues that we want to deal with. All right, so up until then, that was our interviews and our surveys. Now we're starting to move into software engineering, or start moving into this framework. So some of the things that we could do with software engineering, or some of the things that we could do in terms of developing a software system. Look at some information, help people with decision support systems, and this is all around Alzheimer's or all around dementia prevention. Some terminology, provide terminology for people. Come up with some notion of how to detect symptoms, a diagnosis. Geriatric assessment, there's a few geriatric assessments online right now, but we could build this into kind of an all-in-one portal that has a lot of this information in it. So there is, just to give you a sense of what's out there, there is injury prevention software out there right now. There is RSI prevention software, which is repetitive stress injury. So these people who do the same thing with their hands over and over, there's software out there to help them with that. There's AIDS prevention software. So we decided that we would at least think about some dementia prevention software. So our focus is on prevention. Our focus is on current research. Now, I've said 2006 plus, but a lot of the research that I used was actually before that. Things are changing so rapidly, though. There is lots of new stuff on Alzheimer's and on dementia constantly. So we're trying to stay on top of that. Best practices, these are, again, some of the things we could include. Best practices, customization to particular circumstances, and links to risks and treatments and technologies. Some electronic quizzes we could build into a Facebook-like front end. so that we could have the email, the instant messaging, and so on, if it seems appropriate. Again, we'd have to think about who our target market is, whether we want to do that. And a lot of the existing software ties, or a lot of the existing websites, I guess, tie to caregivers and medical staff, because as I said, the older people themselves often can't be involved, or you can't trust things that they say. So we could develop some sort of personal health support system. Risk, symptoms, dementia stages. One of the things that's out there right now is a camera. So you're sitting looking at your computer like this. A camera comes on and tells, like a webcam, tells whether you're depressed, whether you're stressed, that kind of thing. So if we could build this into some sort of dementia prevention, it might give us a sense of how the person is feeling, or how the person is going today. Some of the challenges with this information: large volumes of information. There's way too much information to stick into one little portal. So we'd have to decide what we wanted to include. Large number of sources. Where do we go to get our information? As I said, there's probably at least 100 sources, if not more. Before diagnosis, risk factors. After diagnosis, some medications and support services we could include. So this was our model that we showed you earlier, where we had included all of these different issues that we were thinking about. So we're now starting to move this to a social network model. So for the social network model, we started to think about, first of all, we changed on the left-hand side at the top, we changed that to social network research. So we've looked at social network research. Some of the things that the social network research suggested is this notion of regular contact. People have to be in charge on an ongoing basis. There has to be interaction back and forth. It's very positive to have combinations of things, to have brain activity or physical activity as well as the social network. And then we could build in a variety of games and quizzes. There are games and quizzes out there. There are lots of them, but we can build them into this model. So some of the things we could build in: a geriatric assessment to determine cognitive awareness. So again, there's 10-point tests, 10-minute tests to ask people what's today's day, what's today's month, hour, what's your address, that kind of thing, to give some sense of whether you have dementia or you don't. And these tests are taken on a monthly basis or every 6 months or so on to monitor how people are doing. So this could be built into our software. Another item that's out there is tracking early Alzheimer's. Motion sensors in the house, watching changes in mobility and behavior. And again, on an ongoing basis to look for deterioration. So this is part of geriatric assessment. E-therapy, typing your troubles to a remote psychotherapist. So I like this idea. I think this is an interesting idea. Again, while you're cognitive, it's a good idea. Once your brain starts to go, maybe not such a great idea. Brain age, this is something that was suggested to me by Bill a year ago. He gave me this cute little thing that I could play with, and I could do little quizzes. And there's lots of stuff all over the internet along these same lines. So you just do these things over and over, and there's lots of articles that say both good things and bad things. One of the good things is that people do seem to do better the more they do it. One of the negatives, though, is that maybe it's just improvement with practice. So maybe you're just doing the same thing over and over and over, and you're getting better because you've done it 10 times already. So something along those lines is a good idea, though, to build into this. Another interesting thing is the notion of interactive software. So Maple Leafs recently started this interactive game. So you ask, will the Leafs score this period? Or the system asks, will the Leafs score this period? You answer yes or no. The obvious answer is no. Then, yeah, that's from experience. That's right. So then if you want to kick it up a notch, you don't even have to do, or you go beyond the yes, no. you can say who will score the goal, or the computer will say to you who will score the goal. You come back with a particular name, and then you can win points, you can win apparel, game tickets, and so on. So this is already online right now, but it's again the type of thing that could excite people. So our conclusions: electronic social networks appear to provide the same benefits other than physical activity. So the real concern is whether you need physical activity. Therefore, research results linking social networks and dementia prevention should be equally applicable to electronic social networks. Electronic social networks do not appear to have the isolation problems of some computer work, perhaps because of their interactive and communicative nature. So I think this notion of interaction, rather than just sitting at a computer, I think that makes a real difference. And then some of the contributions, what exactly did we do here? We documented current dementia prevention research. We focused on social network prevention. We extended that research to electronic social networks, and we still have a lot of work to do for sure. Increased understanding of dementia social networks and AD complexities, and developed a dementia prevention model. And I just have three more slides of some interesting things that are possibly coming up in the future. Future prevention research. These were some of the things that I saw as I was doing my work. People are trying to come up with vaccines. They're trying to come up with brain imaging, which is to look inside your brain and see whether you're going to get Alzheimer's or not, or whether you're going to get dementia. They have drugs, blood tests, or they're working on drugs, blood tests, a spinal tap, and surgery to remove tangles that are already there from people who have Alzheimer's. One of the tests, this Alzheimer's test, people were looking at a biomarker, trying to find a biomarker of Alzheimer's, so that they could tell from a brain scan who's going to get Alzheimer's and who's not. So giving brain scans to 800 older Americans, trying to pin down the earliest changes associated with Alzheimer's. And again, if we can catch those changes before Alzheimer's kicks in, then that would be great. And the last slide is the funniest. This one I got from the Record just a little while ago. The notion of cognitive brain doping. Healthy people deliberately taking brain drugs. So this Aricept slows the progress of Alzheimer's. So people are beginning to take it kind of as a preventative, which strikes me as very bizarre. Searching for a memory pill that is better than Viagra. So whether we'll ever see that in our lifetime, I don't really know. But a lot of these drugs, what they were doing was improving concentration and attention, and that's the killer with the dementia kicking in, is that you're losing your concentration and your attention. All right, so I'm done.
Thank you. Yes, applause. I can get microphones to. I'm not sure if I'm working. Am I here? Am I working? Get microphones to. I have two quick questions to start this off. First of all, who's the we?
Who's the we?
The we.
I'm working with two other researchers, also from Southern Ontario, from other universities.
In computer science?
That's right, information systems and software engineering.
Okay.
So it's a computer science focus rather than psychology or
neurology
medicine or neurology. Exactly.
The second question is, and I'll preface this. There's a really interesting editorial about, must be 6 or 7 years ago, in the Canadian Medical Association Journal by a guy by the name of David Sackett, who's one of the people who started clinical epidemiology here in Canada. And he really came down hard on prevention, because we've sold prevention about heart, we've sold prevention about everything, including 8 glasses of water a day. Yep. That has no basis. And we're burning people out. And what we do with prevention, if we're not careful, is get people to blame themselves for their diseases and disorders. In other words, you could have done something about it. Okay. Yeah. So that's the preface. Is what is the level of evidence of the studies that you've actually looked at? In other words, have they been critically reviewed and assessed as to their level of evidence?
They're all being published in academic journals.
By the way, there's a lot of stuff published in academic journals.
I understand that. They're large-scale studies. The Swedish study was very large. The German study was very large. There are large American studies. And by large, I mean 600 people, 800 people, and long-term. Sure. So I would say the evidence is good.
The one thing I would suggest is to have a person actually look at the articles and do a critical analysis. We have a number of people that, a good one is Brian Haynes at McMaster, to actually review those studies. And he may, in fact, have done that for this. I don't know. They have a center. We find that a large number of these have other interests driving them, including people who want to sell nutrition diets, or drugs or whatever it might be. And the level of evidence needs to be characterized in terms of how many people would have to do it before there would be an effect. Usually call it number to treat. It's a very, very important number. So that whole idea of critically analyzing this beforehand, because it may be possible to change a person's emotional state through this, but you may not be preventing the dementia itself, and surely not, there's no evidence that I know of preventing Alzheimer's, for example.
Right. Well, this whole notion of delaying it, I think, is,
You're delaying
where things are
your
going.
perception, perhaps. You may not be delaying the actual, you mentioned that yourself. It may be a perception. So getting that clarified is crucial, but very, very interesting work, and an application, too, of communities of practice kind of concept, same thing.
Right.
Questions?
Yeah.
Well, I had two things. First of all, there was an article in the Globe and Mail yesterday, I think, about the study on nuns who eat well, exercise, have social contact, and lived into their 80s, 90s, some to 100s. They said when they did the autopsies, they found that their brains were riddled with Alzheimer's, but they had no impairment.
Yeah.
So I don't know if you've...
There's a lot of work on that nun study, definitely a lot.
So I wonder if maybe Alzheimer's isn't the issue.
Yeah, there are so many complexities.
And the second one was, it just occurred to me that if you get somehow combine Nintendo Wii with the social networking, they get the exercise and the stimulation.
That's a good idea. Twister, I didn't think of that.
Comment that I would like to make is I think there's also a plug here for people to continue working beyond the stated mandatory 65.
Absolutely.
Because you see, most people have meaningful work and interactions, and they have purpose in their lives. As soon as they hit that magical, or what used to be the magical 65, they lose the purpose, particularly for a certain male genders. They lose everything that was important to them.
Yeah.
And they tend to be generally very socially isolated, other than with the colleagues and people they interchange with.
Yeah, that's a very interesting point, particularly with the work that we were doing, talking to the virtual workers. It didn't cross my mind. I was just going to pull them out of our work, but possibly twisting things a little bit to study that would be very interesting. Yeah.
I think just what the gentleman said prior, that people who have meaning and purpose learn to compensate.
Right.
They adapt in certain ways so they can, if you like,
so they can
use your
contribute.
term, contribute in another way. And
Right.
certainly there is the prolongation of deterioration.
Right.
Because there are so many things. I work in healthcare, and there are so many people we see as soon as they retire. They are now people full of diabetes, cancer, cardiac care, etc.
Right. We actually noticed that at the end of term here. We teach and teach and teach and teach, and then as soon as we've finished teaching, we all get sick. So our body has just said, okay, now's the time. Now's the time. Yeah, interesting.
Just thinking, recently I've been witness to my father retiring. And for such a long time, I believe his social circle was where he worked. And I've seen sort of a really quick just change. And it's not, like, I don't know that he has any real impairment, but I've sort of, it's being a concerned son, noticing my father, who was the smartest man I know, go to looking to me for answers and things in such a quick time. And I feel like maybe realizing this fact, maybe you focus your work on hitting those people right as they retire, and that maybe you can make the most difference there.
Yeah.
And, you know, on a personal, even more personal level, I fear that when I finish my PhD, I'm really going to drop off. And, you know, it's an even worse deterrent. I'm even more concerned because, first of all, getting a PhD, you obviously put yourself out of a lot of jobs. You're overqualified, and then if I can't even do the jobs that I'm not qualified for, but in any case, though, amazing work, and
that's actually a very good point. Very good point.
Sort of a question which is similar to the first one asked. And I'm just curious as to whose responsibility is it to embed these technologies for prevention. So if you have electronic social networks, they're almost always geared towards 20, 30-year-olds. Dementia is an issue for 80. Software is not thinking about this kind of feature now. Do you expect the push to embed these kind of technologies to come from the market forces, or will this just happen? I mean, there are already crosswords out there, but if somebody doesn't want to do a crossword,
that's right. Or if they don't want to do a crossword on the computer, if they'd rather do it on a piece of paper, then you're wasting your time. That's right. But I mean, you see things changing. You see, as I said, even with this Facebook type of thing, we saw people up to age 70 using Facebook. So it was fun and exciting, something new. Let's try it out. So maybe that'll continue with other software.
So what about the specific features which prevent dementia? I mean, how would those be? Is it just coincidence, or is it just, going to happen that we can somehow inoculate our population from dementia by embedding these features in it? So that's the interesting thing.
We'll have to see. Yeah.
Just another quick, did you put your hand up or bidding $5? Okay. You can have her. Do you have slide 11 just for fun? Just go back to slide 11. There it is. 65 prevalent steeply with age, that sort of thing. What's interesting about this is the other interpretation of it is people with dementia live longer. I mean,
I didn't think of that, John.
And it could be that they relax and stop worrying about things, but it just shows you that data can be used in multiple ways. It's not funny. This is true. I know this.
This is why we have statisticians.
Yeah, that's right. I think the other thing that's a confounding factor here is, again, I'm not an expert in dementia. The really big issues are reduction in cognitive function. And I believe the AHS researchers here have produced two really good tests, very short tests, that have become globally recognized, one for testing memory and one for testing cognition. And that the effects of different of these causal factors, from ALS through to Alzheimer's and things like that, each of them has a different effect either on memory or on cognition. So the difference between those two is important. The other thing I wanted to mention is that at least a year ago, Vlad Hachinsky gave a talk here on some of the underlying causes here and disambiguated a lot of this. I'd be interested to see in your group, as you do the basics, is a neurologist involved, who's involved in brain function, because I think a lot of the issues here are easily thought of in a pedestrian way as opposed to a scientific way.
Yeah.
And the evidence characteristics are really important. A final question, unless there's anybody else, is we know that these systems that we have, the phone, if you meet with someone, I can see your face, hear your voice, all that. If I'm on the phone with you, I can hear your voice, but I can't see your face. And if I'm on email, most of the emotion is stripped.
Right.
To what extent is that a factor? I mean, that could be something.
Yeah.
Voice with video could be better than voice, could be better than text.
That's true. That's true. That would start adding a little bit of complexity. But you're absolutely right. Email in particular, people will get into fights when they don't mean to get into fights, just because somebody took something the wrong way.
And flaming, things like where you act in a way that you wouldn't normally act.
That's
but,
right.
I think that what might be interesting is within even the intervention to look at how different aspects of the intervention are more or less effective in the communication, which is a lot easier than measuring memory or Alzheimer's.
Right.
So you can look at sort of internal or process measures. I think the outcome measures here are going to be extraordinarily difficult, if not impossible. Interesting. But anyway, any other questions or comments? If not, sure.
My husband's starting to show the beginning of Alzheimer's, and he's been evaluated as having the beginning of Alzheimer's. How does one encourage these brain games and other games if they don't want to?
Oh, that's a very good question.
I'm constantly having to cajole him into doing these things.
Yeah.
I know they're good for him, but
Yeah,
how
that's
can I
right.
get him to enjoy to do
Yeah.
these things?
Yeah, that's right. The idea is that he has to want to do them himself.
We're facing this problem not just in I'm losing the voice. We're facing this problem not just in the area of Alzheimer's, but in all of the portal technologies. And the issue is motivation. You can't interact with a person to change unless they get them in. So one of the things that's crucial is that the clinical environment has to encourage it and say, boy, there are some things that will help you here. And then when people get on the system, you have to do an assessment of what motivates them. Somebody may be motivated by sports or something else. And when you know what it is, then you need to tune the intervention, the website, for example, the portal, to that person's actual motivational characteristics. And this is one of the things we're working on with Chrisanne DeMarco, is in providing, for example, educational materials, we need to know what motivates the individual before we can write, using natural language generation techniques, an educational text that will motivate them. There's a lot of really good research that's been done on this in the area of tobacco prevention and taking people off tobacco and other drugs. So there may be something in that literature that may give some answers. But the clinical environment connecting to this is crucial. I'm extraordinarily worried about this, not in your case, but in the work we're doing. We're developing portals for clinical purposes, but I worry about the absolutely deep connectivity between the clinical environment, what it encourages and does, and what the portal does. Are they two separate things? Are they deeply interacting? If they're not deeply interacting, I don't think they'll work. I don't think you can do anything electronically that the person won't engage in or that the clinician doesn't support or whatever.
My daughter bought the Brain Age game specifically to get my husband interested into using them. He wants nothing to do with it. What can you do?
Maybe you have to have cute pictures or something on it. And thank you very much. Really enjoyable.
Thank you.